right, welcome back everyone to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. I'm joined again by our co-hosts, Dr. Michael Gannon and Dr. Dixitha Anugula. We're going to rejoin our conversation with Dr. Khurram Nasir as we explore the world of coronary calcium in stable chest pain, access to coronary calcium scoring, and the future of the field. Let's jump into that conversation now.
Thanks, Praveen. Just reintroducing Dr. Khurram Nasir, Professor of Cardiology, Chief of the Division of Cardiovascular Prevention and Wellness, Houston DeBakey, with appointment at Weill Cornell Medical College. Excited to have him back. We had previously a great discussion on coronary calcium and preventive cardiology, and now we're kind of moving into another more controversial area, which is the use of coronary calcium and coronary CT in acute and stable chest pain, and we'll also touch on some health equity issues within coronary calcium and preventive cardiology.
How does the CAC score apply to stable chest pain patients or even acute chest pain populations?
Well, that's an area that's kind of been heavily controversial for many, many years. And, of course, one of the key things that always come in is calcium scoring at chest pain. Is it dead on arrival? So, before I go in, I would definitely like to ask back the host, what's your concerns about using calcium testing in chest pain patients?
Khurram, it's a good question. And while I'm just going to paraphrase the response from others around me, I think the summary would be this. The current paradigm of evaluating either stable or acute chest pain involves what would be described as anatomic or functional imaging. A lot of facilities that I've practiced at use primarily functional imaging, as that has been the standard for several decades. The intent is to determine whether or not there is myocardial ischemia that may be contributing to the symptomatology causing the presentation of that patient. To reduce the myocardial ischemia to presence or absence of coronary calcium is thought to be a step too far. Now, we may have data to argue against that, but that's what I anticipate some of the critics of introducing coronary calcium into the chest pain world may say.
Right. And I completely agree. And honestly, that's a major issue. So, where I'm looking from, the prism and the lens where I'm looking from is, of course, not everyone is a candidate. Even if you're coming with chest pain, there is a step behind where we call the pretest probability, right? So the general recommendation, if you are intermediate to high risk, then pursue with more advanced imaging to understand whether you have anatomical obstruction or ischemia, and a major part is to rule out. But historically, we clearly know that the pretest probability, even with the updated version, significantly overestimated. Let me give you an example. I was just having a conversation with one of our fellows, a patient, 59-year-old, coming in with some typical atypical chest pain, pretest probability intermediate, and asked, what would you do? And the answer was like most of the places where they are going to have a stress myocardial perfusion imaging. So my response was that fellow can sit in the same room and read every nuclear test for this patient coming in and call it a normal, and they will be almost 90% correct. So in essence, and this is based on the old data by Alan Rozensky that clearly shows that only 10% of stress myocardial perfusion imaging are abnormal, and the ischemia is even lower, 5, 1 in 20%. And even in the contemporary data, if you look at the PROMISE study, only about 11% in the CTA group and 11.7% in the functional test group had abnormal studies. So in essence, almost majority of the studies are normal. And where I'm looking, are we doing too many advanced cardiac imaging testing? And if we believe that the healthcare puck is moving into the value-based medicine corner, I don't think we'll be able to afford a majority of advanced tests being normal. And in this regard, I believe that calcium and the power of zero can act as a gatekeeper. And of course, the major concerns are, well, I'm not too comfortable sending someone home back with a calcium score of 0 in a chest pain, because every 6 months I do get one case from a friend, a colleague, or on a Twitter showing an obstructive disease with a calcium score of 0. So the concern is that the calcium score does not exclude significant coronary artery disease. So I'm talking about stable chest pain right now, but what's the data? If you look at confirmed study, the negative predictive value was 98 to 99% to rule out obstructive disease based on CTA. The most robust data is from PROMISE. The negative predictive value to rule out greater than 50% on a CTA, which seems to overestimate, was 99%. And of course, then the second concern is, Praveen, you just pointed out, every day we send back home after a normal stress test a patient who has chest pain and a normal stress pain, we are pretty reassured. But at the same time, we may not be reassured with a calcium score of 0. Now, does that mean that the risk of an event is higher with a calcium score of 0? Actually not. If you look at the PROMISE study, with a normal functioning test, about 1.3% individuals had a cardiovascular death or myocardial infarction when it was normal. Guess what? What was the death rate and cardiovascular death MI rate? It was 0.6%, twofold less. And as a result, Matt Bodoff and Udo Hoffman were supportive of the role as a calcium as an initial test, followed by a second test if it's only positive, the same mechanism I have spoken about, not as a diagnostic test, but as a gatekeeper. And even if you look at data from Europe by Tarun Mittal and Adam Timmis, 3,000 patients underwent calcium testing and CTA as usual. The negative predictive value was 99.5% to rule out obstructive disease. They followed them for up to 13 years. And guess how many individuals had a coronary death? 0. That led them to say, well, the anatomic, which you mentioned, and the prognostic data of calcium scoring is robust for identifying low risk. And like me, they also question the need for further testing when the score is 0. And secondly, you pointed out about ischemia. Yes, there are studies that suggest that about 5 to 6% may have some ischemia, but now we know those are exclusively mild. But Praveen, if you look at individuals who have a calcium score of 0, even when they have ischemia in 5 years, in an intermediate risk population, the event rate was the same. And now we have some work ongoing with Mohammed Modern that's looking at up to 12 years, and it's a flat line. So there is no differences. And based on this data, Alan Rosansky, Dan Berman has clearly suggested that we should avoid any further testing among those with chest pain if they have a calcium score of 0. Now I'm going to come up to something that's more controversial. But before I go ahead, so from stable chest pain, if you look at the data is there truly to suggest that it can add as a supplement gatekeeper. Of course, I'm not asking as a diagnostic test, and the data clearly suggests that by doing so, we can significantly reduce the need of more advanced imaging, including SPECT myocardial perfusion imaging, and even identifying the right people for CTA who would actually benefit. And I believe that now CTA being in the truly pole position will well establish the number one choice for evaluation of CAD in most situations. It's adopted worldwide by guidelines in US, in Europe. So I think the CTA community is in a position of strength now, and that can allow us to do 3 things. Let's question our current assumptions and activities, and let's envision possible future needs and challenges, which is clearly that we're possibly doing too many testing, and let's generate new ideas with greater opportunities. And I think so incorporating calcium testing as a gatekeeper truly represents that. But before going to the acute chest pain, wanted to see if you guys have any comments or thoughts.
Yeah, I agree, Dr. Nasir. It's a difficult question, and I think when you do it, as you've pointed out, the percentages are low. If you see enough patients, inevitably, you see people who have a calcium score of 0, who have some soft plaque, who have obstruction. And so I guess the question is, as you've mentioned, what does that change in terms of their outcomes? And I think in the stable chest pain patient, within cardiac imaging and with the ischemia trial, I think we are almost kind of backing away from of being more aggressive with these people, understanding that medical management can help these people and that we're not necessarily putting patients at risk by not doing more aggressive testing in the stable chest pain. So I kind of do agree. I am interested in your thoughts of acute chest pain, people presenting to the emergency room, because although I think that represents a slightly different population, although it's two chest pains, I think the timeline of the chest pain is slightly different. And I was just wondering if you felt as strongly with the acute chest pain as the stable chest pain.
Yeah. So, Mike, this is an interesting dilemma, right? So, whenever I have this conversation around acute chest pain, it really throws me back to 2000, to my one of my favorite movies, Matrix. I don't know if you guys have ever had an opportunity. I'm sure all of you were too young to see that in the theater, but the main character Neo, he's offered the choice between a red and a blue pill by the rebel leader Morpheus. And the red pill is an uncertain future. It would free him from the control of this machine generated dream world. But so I remember the conversation say, you take the blue pill, the story ends, you wake up in the bed and believe whatever you want to believe. And if you take the red pill, you'll stay in the wonderland, and I can show you how deep the rabbit hole goes. So the question is, all I'm trying to offer is the truth, nothing more here. So let me come back to your question about the concern is definitely in the shorter period acute chest pain. But Praveen and Mike, would you be assured sending somebody who comes with a chest pain, maybe atypical chest pain, you observe them overnight, the troponins are negative, you take them to a stress test and they have a normal stress test? And that's what I did as a fellow. There's still I would say the number one practice in US. Would you be comfortable sending somebody home with that features?
Well, Khurram, I think we've been taking that blue pill for quite a long time now.
So yes, and if you look at that's kind of the thing. But at the same time, if I ask, would you send the same person who has a calcium score of 0 in that setting home? I'll be honest, I will be concerned myself because of just what's going around us. So that's kind of where we are. But we have to take a step back and say, what does the data suggest? First of all, let's be very clear. There is no such thing as a zero risk, Praveen, Mike, and Dixitha. And even a normal CTA doesn't afford that. Let me give you some data on that. For example, in Scott Hart study, and I'm going back to the stable chest pain patients. So in the Scott Hart study, there were 41 acute MIs. 4 out of those 41 MIs had a calcium score of 0. That means almost 10% of people with calcium score of 0 had an MI. So 10% of all the MIs had a calcium score of 0. Now, ask another question. How many of these 41 had a normal CT angiogram at baseline? Actually, 3. So the added value of identifying that one patient who actually had an MI was just 1 from calcium to a CTA out of those 41. So not huge. So the concern is, as you pointed out, is in acute chest pain, what's the value of a calcium testing? Now, if you look at how in the ED setting, usually it's considered anything that's a 99% predictive value is considered safe enough for a discharge. That's what we do with the PE. And even if you look at the papers by Udo Hoffman and other guys, they've suggested that not only you have to have a 99% negative predictive value, but that 95% confidence interval for ACS should be in that 1% threshold. So let me remind you of a great paper by, I think so, Brian Gosjara. He's on the leadership committees for SCCT. From Mass Journal, what they found out with the calcium score of 0 and including the TIMI, you have a 99.7% negative predictive value for ruling out obstructive disease that you and I would be concerned about in an acute chest pain. But what about ACS? It's actually 100%. So that's the power of the data. Secondly, we also just recently published the calcium score of 0 for ruling out ACS. In nearly 5,000 individuals who presented to ED who had a chest pain, we looked at their calcium score. We found that the negative predictive value to rule out obstructive disease was 99.3%. And to rule out ACS was around 99.8%. And we considered ACS if you needed revascularization. So, how do you put that into the context with the normal stress myocardial perfusion imaging or a stress echo, which is routinely employed? The negative predictive value is in the low 90s at the most. So, in that capacity, I really question that how are we going to proceed with the calcium score of 0? And a great answer for that was provided by John Memarian and Faisal Nabi at Methodist, where they took 1,000 patients and normal troponins, negative EKG of any ischemia. And of course, everyone went stress myocardial perfusion imaging, so they added the calcium score. And in a normal stress test, only about 0.5% with the calcium score of 0 had any ischemia. But more importantly, if you look at the 7% outcomes, so Mike and Praveen, with the normal stress test, the outcomes in the follow-up was 1.2% in a normal stress test, which is pretty reassuring. That's within the limits of what our societal cutoffs are. Now, what would be a cutoff for the calcium score of 0? It was actually 0.3%. So Mike, Dixitha, and Praveen, I still remember a debate at SCCT when one of my colleagues asked me point blank and say, how would you sleep at night sending somebody in an acute chest pain sending home with a calcium score of 0? And my response was 4 times better. And, this is based on data. This is not based on what I believe or what I perceive. I'm just saying that in a society where the number one rule out test is stress myocardial perfusion imaging or stress echo, and we are extremely comfortable, then we should be at least 3 to 4 times more reassured sending someone back home with the calcium score of 0. If our expectation is that we do not want to miss a single case of obstructive disease or ACS, then we definitely have to stop using stress myocardial perfusion, any sort of functional testing, including calcium testing, and everyone should get a CTA. And even, by the way, as I showed you, that a CTA is not a foolproof. It's a very reassuring test, but you're still going to have an event. So we just have to change our mindset and make sure we value diagnostic and prognostic information of different tests the same way. We cannot give a class 1A recommendation to a stress myocardial perfusion imaging that has a much lower negative predictive value and a much higher adverse event rates, and then at the same time suggest that calcium testing should be a class 3 or a 2B for the same patients, where it reassures more as far as obstructive disease is concerned, and even a much more favorable prognostic. So all I'm asking is a fair evaluation. And if you look at through that lens, then it becomes much easier.
Thank you. I think that very good points and important points too is not just the question of how good is coronary calcium power of 0, but looking at it in the context of what we currently have and accept. And so I think that's very interesting. I don't want to take too much of your time. I did have one more question just about, given your background in health equality, and there's so much, everything we've talked about is, the power of your using calcium scoring in prevention. And so personally, I work in a low income area that despite understanding and wanting to use calcium scoring, I've only been able to have 2 patients in the past 2.5 years actually get it, pay for it out of pocket. We try and use it if someone has a chest CT, but kind of was wondering your opinion on the barriers to calcium scoring and cardiac prevention, and if you think this is going to be changing in the future, as it disproportionately can affect and affect access in different income groups.
This is a highly critical issue, Mike. As you know, as preventive cardiologists and imagers, we should all be very proud that we have seen a significant improvement in cardiovascular disease burden. The treatment adherences and the right people getting the right treatment on the right time has significantly gone up. But clearly, those gains have not been equally spread out, with a lot of disparities in our marginalized communities and especially low income groups. So now the question really is, the CMS is still looking at it through the lens of screening test, and they're asking for a clinical trial for it to happen. But I think the ACC needs more, I would say, support in the Congress to make sure that we have it reimbursed. Now, I just want to make sure that when it gets reimbursed, that the cost of out-of-pocket costs is still within within the limits of affordability and doesn't get too high. Because if you're going to have a test that's $600-$700 and you still have to pay $100 out of pocket, then it's slightly higher than what we have. So currently the situation is, depending upon which part of the country you are, most of the tests are $55 to $150, a median around $100. In my experience, there are few things that can happen, and one is a more clear discussion with the patients and suggesting and guiding them that if they are able to afford a $55 to $100, and of course, not everyone is privileged enough, but it can provide them the information to guide their management for the next 5-10 years and help them on issues like aspirin. And of course, statin is pretty cheap, but aspirin has its own side effects. You see a lot of individuals coming on aspirin or who may benefit from aspirin. So that's a question that happens. I'm definitely trying to have more conversations around the diabetic patients and trying to help them understand whether they would be candidates for more aggressive treatment. So in my experience, and I've had the pleasure of working in both situations, having that conversation significantly shifts the perception from the patient that they are investing that $50 to $100 in their health, not right now for their long-term health. And unless and until you are extremely in a group where even a $55 to $100 can be a challenging, most of them folks are able to afford it. And even if they don't pay it upfront, they'll say, we'll have it done. There are other mechanisms. For example, many systems at Sanjay Rajagopalan in Ohio, they have a free program now for calcium testing, which is a community benefit. I think so. That's great. It has clearly shown that it increases the participation of the marginalized community and especially also women. The third piece that needs to happen, actually, I was in a conversation with some folks in Broward County that are thinking about leaving a minimal tax to help support some of the calcium testing. But I totally agree that all of us need to continue to advocate the ACC, the SCCT to get it reimbursed, covered by insurance, and more importantly, work towards making sure that the co-payments and co-insurances are not a barrier, but in the interim, having more detailed conversation to see whether there may be a possibility for these patients to pay it out of pocket, and also look at financial resources within our own institutions. At times, you will find that there are some funds and resources to support these low-income families.
Khurram, I think the reason we've been able to have such a rich discussion thus far on preventive cardiology, on chest pain, on access in the context of coronary calcium is because we have so much data on this. And we've been doing it this way for, as you had mentioned, since the 90s, since the days when electron beam CT was in vogue. That said, there is some recent interest in different ways of analyzing those same coronary calcium data. For example, different technical approaches using different attenuation weighting or even potential quantification on contrast-enhanced imaging. Can you comment on whether there's fruit to be borne in these new techniques or whether the Agatston calcium scoring method is there for the long haul?
So to start with, I think so the calcium scoring is there for the long haul. doesn't mean that we cannot refine along the edges. And my colleague Mike Blaha and other have been very active in this space, and I have the privilege to participate. So when I say the calcium scorings, they're going to be to stay, I mean that the plaque burden. So, you have two extremes where you have the calcium score of 0 and then the calcium greater than 100 or 400. Now, of course, in the middle, which is about 35% of individuals, things that are going to be critically important. Number one, what's the regional distribution of calcium scores? For the same calcium scores, if you have more distributive, more vessels, slightly higher risk, we have to take into account lesion size and shape. We have to look at some of the plaque density. But when you take even all of these things account, none of them time the burden. And when I mean, for example, you may have individuals with a calcium greater than 100 with more denser plaque, and individuals with calcium score of 10 to 50 with less denser plaque, but the outcomes would be worse. But within each calcium score group, these things will provide more information. I truly believe that now, with more automatization and machine learning and AI protocols, they will be able to overcome some of the challenges which are more operational in calculating and determining that and giving a more refined calcium score. There's a lot of work happening in this group by many innovative companies, groups, and even folks like Sumin Cheng at Houston Methodist. At the same time, I definitely believe that for two areas, for de-risking and identifying patients who are at high risk and convincing them to take medications, the calcium burden will still remain prime. And the rest of the information in between will be further refined by many of these parameters. And I'm very excited about that. But truly, the burden, the calcium score is here to stay. Of course, much more refinement needed for the middle group. And you'll be seeing a lot of work coming from these groups soon. Some of the meetings at SCCT, ACC, and the journals like JACC Imaging and JCCT.
I wanted to thank you, Khurram. I know we've gone a bit over time, but I think we've had a really, really great discussion on hitting a lot of topics within cardiac CT, coronary prevention. So I really wanted to thank you for joining us. And if Praveen or Dixitha had any other last comments as well, I think that we've had a really great discussion.
I agree with you, Mike. Excellent discussion. And if we have Dr. Nasir on board, we could keep talking the whole day and get a lot more great information for him. Thank you, Dr. Nasir, for joining us.
No, thank you so much, all of you guys. This is a fantastic podcast. Keep up the great work. By the way, not only this, but again, fantastic discussions on the Twitter by all of you guys and the rest of the colleagues. I think the more we challenge ourselves, the more we push, the more we will start understanding where the role of the calcium testing, not only alone, but I think so within the emerging capacity of the CTA in finding the right patient that will benefit from more advanced testing. So again, really appreciate having me on board. I look forward for more conversation in calcium testing and beyond with all of you in the future. Thank you so much.
Khurram, thank you. It really was a pleasure speaking, and we always appreciate your insight into keeping us up to date on the world of calcium. Mike and Dixitha, thank you very much for joining us as our new co-hosts on the podcast. To our listeners out there, thank you for tuning in. Once again, this is the Donut of Destiny. Cheers.